Hello everyone, welcome to Regeneration Hub Pune, where we try to simplify some of the complex, hard and soft tissue augmentation procedures around teeth and implants. Gingival recession is a common mucogingival deformity. There are variety of root coverage options available. There is no doubt that coronally advanced flap along with connective tissue graft is considered to be the gold standard for root coverage. But it comes with some issues like morbidity and limited availability of the graft. There are certain alternatives to these connective tissue grafts. Our today's focus will be on one such alternative, that is Autologous Platelet Concentrates. So we are going to dive deep into biology of platelets, different types of autologous platelet concentrates, how to prepare them and how to include them into root coverage. There are some basic questions remains in my mind as well as your mind, like can we include them as one of the root coverage options? Can we incorporate them as an alternative to connective tissue graft or in combination with connective tissue graft? And how to seamlessly incorporate them into root coverage options. Let's dive in. There are variety of root coverage procedures for the treatment of gingival recession, like coronally advanced flap, CAF, tunneling procedures, and many more. Coronally advanced flap along with connective tissue graft is considered to be the gold standard treatment for root coverage as shown by numerous studies. However, there are certain drawbacks of connective tissue graft. Those can be patient-reported outcomes like increased invasiveness, post-operative discomfort, time taken for recovery, or collateral harvesting complications like greater palatine artery injury, intraoperative bleeding, palatal flap necrosis, change of feeding habits, sensory disorders, or epithelial cyst formation. To overcome these drawbacks of connective tissue graft, few connective tissue graft alternatives are available. Those are graft substitutes like allo and xenogenic derived graft substitutes, or biologic agents like autologous platelet concentrates known as APCs, enamel matrix derivatives, or recombinant human platelet derived growth factors. Autologous platelet concentrates or APCs are blood derived products obtained after the centrifugation of a patient's own blood containing activated platelets enmeshed within a fibrin matrix scaffold. They aim to accelerate and promote natural healing and regeneration of both soft and hard tissues by concentrating platelets, leukocytes, and other therapeutic constituents of blood such as fibrinogen, growth factors, cytokines, and circulating cells. The blood is composed of cells like RBCs and WBCs and cell fragments like platelets. The circulating platelets are non-nucleotide cell fragments released from large bone marrow megakaryocytes and regulated mainly by thrombopoietin hormone. In humans, normal platelet count varies between 1.5 lakh and 3.5 lakh cells. The total number of platelets in different APC preparations mainly depends on the preparation protocol. Platelets contain three types of granules: alpha, dense or delta granules, and lysosomes. The majority of platelets proteins or biomolecules are released from the platelet alpha granules. Activated platelets release their granule content including nucleotides, adhesive proteins, several growth factors like platelet-derived growth factor, vascular endothelial growth factor, transforming growth factor, and epidermal growth factor, angiogenic factors, and cytokines, which are of crucial importance to trigger the healing cascade. For example, platelet-derived growth factor helps in recruiting progenitor cells, induce fibroblast proliferation, migration, chemotaxis for macrophages, collagen synthesis, and secretion of cytokines. The action of APCs are based on the growth factors stored in platelet granules and on their release after platelet activation, which triggers the healing cascade. The rationale of using APCs is to reach an elevated supraphysiological dose of growth factors to enhance the natural wound healing process. Various authors have given different classifications of autologous platelet concentrates. Amongst them, one of the most commonly used is the one given by Dohan. In this, Dohan classifies APCs into four classes. They are PPRP, that is pure platelet-rich plasma. Second is LPRP, that is leukocyte platelet-rich plasma. Both of these are considered to be of first generation APCs. The third one is PPRF, that is pure platelet-rich fibrin, and LPRF, that is leukocyte platelet-rich fibrin. The last two are considered to be of second generation. The difference between first and second generation APCs is there is need of anticoagulant and activator in case of first generation APCs. This complex procedure is now simplified in the second generation APCs, where you need only one cycle of centrifugation and there is no need to add anticoagulant or activators, resulting in a high density matrix. The advantages of using these second generation APCs like PRF are enhanced healing, wherein leukocytes in PRF boost wound healing and tissue regeneration. Second is PRF avoids anticoagulants, preserving the natural healing process. The third one is PRF's fibrin network ensures a gradual growth factor release. In the preparation protocol as proposed by Chokron, the centrifugation process should begin no longer than 1 minute following the onset of whole blood collection. Patient's venous blood is collected in dry silica-coated or glass tubes and is immediately centrifuged, resulting in the formation of three layers: RBC base layer, platelet-poor plasma, and LPRF clots. After the PRF is collected from the test tubes, the RBC layer is often closely intertwined with the fibrin clot containing the LPRF exudate, which is populated with growth factors. Thus, careful separation with specialized instruments resembling a spatula is usually undertaken. Upon gentle compression of these LPRF clot for 5 minutes, a strong LPRF membrane is formed which has a high concentration of growth factors, leukocytes, and platelets. The favorable biological properties of PRF membranes are strength, sustained release of high qualities of growth factors over a period of 7 to 14 days, and to provide a fibrin matrix architecture that can be populated by a plethora of cells, which is useful in the process of tissue regeneration. The stability of LPRF formulation relies on its storage in a sealed compartment at room temperature to prevent dehydration. If stored under these conditions, LPRF can remain unchanged for 2.5 to 3 hours. There are different modifications of PRF and each has different protocol regarding centrifugation RPM and time. For example, original Chokron's LPRF needs 3000 RPM for 10 minutes. Other modifications are APRF, APRF plus, then liquid format of PRF like IPRF, then we have TPRF where titanium tubes are used, then we have concentrated growth factors where variable centrifugation times and RPMs are used, and the recent ones, that is CPRF. There are lots of studies comparing PRF to connective tissue graft in treating gingival recessions. These are just some of the studies that are mentioned, who all have shown positive results as far as root coverage is concerned. One recent systematic review and network meta-analysis by Baruchi et al. In 2025 showed that the use of APCs for root coverage procedures was found to be overall effective in reducing the amount of gingival recession. PRF was the only platelet concentrate that significantly enhanced clinical root coverage outcomes of CAF alone in terms of mean root coverage, while PRP and concentrated growth factors did not. keratinized tissue at baseline was significantly associated with the final mean root coverage of PRF, which means that the more keratinized tissue width at baseline, the better the root coverage outcomes would be. This review also noted that biologics have shown capable of promoting root coverage of recession defects when applied in combination with matrices or scaffolds. In case of multiple recessions, combination therapies may also be recommended instead of or combined with autogenous connective tissue graft. Also, autogenous grafts should be preferred at sites with deep recessions and at sites that lack keratinized tissue, while combination therapies should be considered at sites having a consistent band of keratinized tissue. Let's move to our case where we have a multiple gingival recessions with maxillary anteriors that is treated using intracellular tunneling, VISTA, along with this autologous platelet concentrate in the form of platelet-rich fibrin. This patient complains of sensitivity with upper front teeth. On examination, there is gingival recession, some places RT1 and few sites RT2 recessions. There is adequate keratinized tissue as well as gingival thickness. We have kept the instruments ready for tunneling along with PRF, which includes regular surgical instruments like BP handle, microsurgical blade, brace securates, tissue forceps, micro needle holder, micro scissors, and 6-0 monofilament suture material. We have a 12 number blade, microsurgical blade, then we have a 15C blade, a double-ended Orban's knife for tunneling procedure. We also have different tunneling instruments. This one is relatively straight one, double-ended with a smaller and larger end. Then we have another double-ended instrument which is a combination of straight and an angulated one. And we have a double-ended both angulated ends. We also have micro tissue forceps and a micro needle holder. We start the procedure by using 12 number blade to give intraclavicular incisions at all the sites, since this is a procedure from canine to canine. Then after we shift to the microsurgical blades and try to go little deeper before we start or put the tunneling instruments. Once we achieve some space, we can use different types of tunneling instruments. Here we are shifting first to the Orban's knife to separate the gingival fibers on left side as well as the right side. After the use of Orban's knife, we are shifting to the tunneling instruments at all the sides, entering slowly at other sides. Then after using a 15 number blade or a micro blade, we are giving the VISTA incisions. The two incisions are given between central and lateral incisors, and using those two incisions we are using the tunneling instruments to create the space and shift the gingivopapillary complex coronally. We are also using few more tunneling instruments, sharp ones, to create space on left as well as the right side, going beyond the canines. Now we are trying to lift the interdental papillae. Here we needs to be much careful not to tear the papillae. Once we achieve some space to raise the papillae, we can again use either VISTA or the intracellular axis to mobilize these flaps. Again on both sides, trying to shift the papillary complex down. Here we check how much release is obtained. If needed, we can continue with few more instruments. Here we are shifting to the greasy curate, especially for the papillary areas, and finally we confirm the release using the graduated probes that adequate papilla release is obtained. The next step after confirmation of the release is preparation of the PRF, for which the venous blood is withdrawn and it is sent for centrifugation process. Once the PRF is obtained, it is taken out from the test tubes and kept in a PRF box. To obtain the membrane, we need to cover it lightly using the lid. In between, we start with the suturing of these multiple recession sites. The flaps are released, so sutures should hold onto these multiple composite interdental stops. Here, one can use variety of suture techniques like sling and tag technique, belt or belt and suspender technique. In this case, we are using belt and suspender suturing method using PTFE suture material. The technique involves different steps like interdental suturing and then facial bracing of the gingiva to the tooth surface. The interdental stops, composite stops, they act as anchoring stops for the suture material. Now we are separating the RBC layer and cutting the PRF membranes to be able to push it through the vista axis first and later on through the crevicular or intracellular axis as well. In this case, we are using two membranes, especially for the 1-1 site, since the 1-1 had more recession compared to other sites. And we are closing down the sutures, cutting the sutures. In a similar manner, we will be treating other areas, again pushing some membranes through the vista axis hole for 2-1 site and now through the intracellular axis for the same site. Finally, giving sutures for a better adaptation of the flaps. In a similar manner, one can insert many PRF membranes. Now the lateral incisor is being treated. Once all the PRF membranes are done with, we close down the sutures, irrigate the areas, and also one has to suture the vista holes that are given in the vestibular area. So both the vista sides are closed. So this is the final post-operative video of the site, right as well as the left. This is the front view where all the recession sites are covered using the suture material and taking anchorage from the composite interdental stops. This is comparison of pre-operative and immediate post-operative facial view. Then we have left side pre-operative and immediate post-op, and the right side comparison between pre and post. So some of the key takeaways from these presentations are autologous platelet concentrates like PRF are useful in procedures like root coverage. Their main indications are when keratinized tissue is adequate in case of gingival recessions. and they can be combined in case of specially multiple recession gingival defects along with connective tissue grafts. Thank you all for watching. See you soon in the next video. At Regeneration Hub Pune, we have a variety of surgical workshops for clinicians who want to upgrade their clinical skills. These include hard tissue augmentation workshop, wherein we teach variety of flap incision, flap release methods, different periosteal release methods, different suturing techniques, with focus on techniques like socket preservation, socket shield, ridge split, and many more. In case of soft tissue augmentation techniques, we teach variety of root coverage procedures as well as augmentation techniques around implants. We also have a soft and hard tissue combination masterclass. Feel free to contact us for these workshops.